we're going to see sulfonilureas. Sulfonilureas act as insulin in the sense that, remember that the release of insulin from the beta pancreatic cell is when the increase in NADH ratio to NAD or increase in ATP to ADP. When this ratio increases, this closes the potassium channels. So because there is increase in the potassium channels, increases the positive charges here, and so the cell depolarizes. When this happens, there is calcium that goes in, and this calcium that goes in promotes the fusion of these vesicles that contain insulin, and so there is release of insulin. Sulfonilureas blocks these potassium channels, and so promotes the release of insulin. These do not work in patients with type 1 diabetes mellitus because the beta pancreatic cell is not functional. In type 2 diabetes mellitus, there is still function of the beta cells. Sulfonilureas are not the first line treatment because if we increase the insulin release, the insulin promotes that the adipose tissue and muscle cells take in glucose, and so we are increasing the obesity that was the original problem that leads to type 2 diabetes mellitus. So we begin with metformin, and if the patient is not controlled with metformin, we give sulfonilureas. Or if the patient was on sulfonilureas, we give metformin. But the first initial drug is metformin. Now we have first and second sulfonilurea generation. The first generation is chlorpropamide and tolbutamide. The second generation are glyburide, glimepiride, and glyburide is contraindicated, or at least we should decrease the dose in patients with hepatic failure. But glyburide is the drug of choice, sulfonilurea drug of choice, because glimepiride causes more hypoglycemia or increased risk of hypoglycemia than glyburide. The adverse effects are hypoglycemia and weight gain. So it should not be the first line treatment.